Order. Jamie Stone to move the motion.
Thank you, Mr Mundell. It's always a pleasure to speak under your chairmanship. I beg to move that this House has considered e-petition 751839 relating to the clinical trial into puberty blockers. And I want to begin by sincerely thanking everyone I met in preparation for this debate. The legal and medical professionals who share their expertise, as well as individuals with deeply personal lived experience on both sides of this discussion. And it goes without saying that this is a complex topic, and I want to place on record my gratitude for the time and care people have taken to help inform this debate. I'd also like to thank petition creator James Esses and petition supporting campaigner Kira Bell, whom I had the pleasure of meeting ahead of this debate and who are watching today. Their petition asks that the clinical trial induced puberty blockers be cancelled. They believe that medical intervention in this area is dangerous, poorly evidenced and ethically questionable, and they've asked Parliament to ensure that children are protected from potential harm, Mr Mundell. Now, I want to make it crystal clear about the purpose of this debate. It is not about trans rights, nor about whether people who identify as transgender have the right to exist or live free from discrimination. This discussion focuses on a clinical and ethical issue: whether puberty blockers should be prescribed to children experiencing gender dysphoria, and specifically whether a new NHS-backed clinical trial into their use should proceed. Now, puberty blockers are medicines that suppress the production of sex hormones. They press pause on puberty, delaying changes like periods, breast development, voice changes, and facial hair growth. Historically, they have been prescribed to children who enter puberty unusually early, and in some cases for the treatment of cancers or endometriosis. Importantly, they are distinct from gender affirmation or cross-sex hormones. Blockers temporarily pause development, while cross-sex hormones actively induce the physical changes of the opposite sex and are generally irreversible. Now, the petition raises two main areas of concern: the possible long-term medical side effects of puberty blockers and the issue of whether meaningful consent can ever be obtained from a child or adolescent. James Esses, I will give way.
I thank the honourable gentleman for giving way, and he's making a very good start to his speech. But I really appreciate that this is very contentious, but also the manner in which young people, children, are asked questions. Kids Screen 10 is a primary outcome measure for the Pathways trial, and when I look at the questions, I wonder how my son would have answered these aged 11. One of them says, have your parents treated you fairly? And the truth is, any child would probably say no at that age. So does he share with me the concerns that these questions are not fit for purpose?
I thank my honourable colleague for her intervention. My colleague will understand that it is my job as chairman of the Petitions Committee to present a fair, if you like, description of both sides of the discussion, and this I hope to do so. Now, James Esses is a psychotherapist who started the petition. He impressed on me the benefit that good psychiatric intervention could have without medicalisation. Puberty, he argued, is rarely a picnic for anyone. It can be confusing, uncomfortable, and sometimes miserable. But it's an essential development stage. Suppressing it pharmacologically could alter physical and cognitive development in ways we don't yet fully grasp. His argument is not to remove care for children experiencing gender incongruence, but to focus efforts onto careful psychological support. Others question the trial's purpose, noting that puberty blockers have already been paused for new NHS patients with gender incongruences following concerns about safety. They fear that authorising a new trial implies a level of confidence that the evidence base does not yet justify, arguing that enough data exists to recognise the potential harms. These are from reduced bone density to uncertain impact on brain development, continuing continuing could erode the safeguards that protect young people. I will give way.
I'm grateful he's making great efforts to be balanced in his presentation on behalf of the Petitions Committee. And he says this is a complex area, but surely it's actually quite a simple area. We shouldn't be experimenting on children, particularly as you cannot do double-blind experiments. So there are two fundamental reasons why these so-called experiments shouldn't go ahead.
I thank the honourable gentleman for his intervention. I note the sincerity with which he makes his remarks. Then there's the legal and ethical question. Can a child ever truly consent to something like this? On that point, I give way.
I thank the honourable member for giving way. I have 5 children, and I've watched half of them go through puberty, and they continually change their minds for things. And ethically, I can see no justification to allow children to be experimented on for what might be a short-term solution, could be permanent solution for them that they often go to regret.
I thank the honourable member for his intervention. It is, I believe, said with equal sincerity to the previous intervention. I will give way.
Before he resumes, could I just ask him, we know that many children were treated, I believe, with puberty blockers amongst other drugs before the GIDS programme was closed down. Does he know what has happened to all the data from all those children who were previously treated, and why should it be necessary to treat any more children until time has elapsed to enable that data and its consequences to be verified?
I thank the honourable member for his intervention. What I'm about to say, I think, does reflect on his intervention, and it is this. It is not unusual in medicine for children to participate in clinical trials, provided that there are robust safeguards, clear parental consent and proper oversight. But can a distressed teenager and a family desperate to help truly grasp the long-term implications? Now, the legal expert I consulted spoke about the delicate ethics at play. Medical research always involves balancing competing risks. The risks of harm from an intervention versus the risks of harm from withholding it. Puberty blocker trials pose unusual challenges as they cannot include placebos, and so the design requires special scrutiny to ensure informed consent is meaningful. There is still work to do to ensure children and parents fully understand what entering a study means. On the other hand, opponents of the petition, those who support the new trial, say that the only way to reach clear conclusions about safety and efficiency is through rigorous, carefully monitored research. We don't yet know about potential harms of puberty blockers for treating gender dysphoria, but we do know that the effects of cross-sex hormones can be irreversible. Following the CAS review, NHS England proposed a very different approach from the old Tavistock model, focusing on smaller numbers and much, much stricter controls. The new design would have national oversight, tight eligibility criteria, and a multidisciplinary team around each young person, and only about 5% of participants might receive puberty blockers, compared with the around 27% who were prescribed them while at Tavistock. Also important is that cancelling the NHS trial would not prevent young people from accessing puberty blockers. In some gender clinics, clinicians report that between, can you believe, 10 and 20% of clients are obtaining them privately or online, outside regulated healthcare systems. These unmonitored routes carry greater risks because dosages, purity and outcomes are not tracked or supported. Proponents of the trial point out that, without direct research, we remain in a state of uncertainty, which carries its own risks. If puberty blockers help some young people avoid serious distress, we need to understand this better. If the evidence ultimately shows that risks outweigh benefits, that too must be established through high-quality data. Without such evidence, none of us, doctors, parents or policymakers, can make sound judgments. Of course, participation in any trial is voluntary, Families will continue to have the right to decline. The aim of the study is not to push young people towards any one outcome, but to understand what supports are appropriate for different individuals. I want to end my speech by returning to the people at the heart of this issue. I have spoken with individuals who feel deeply harmed by medical intervention, such as Kira Bell, whose story has been widely discussed. Her experience matters, as do the experiences of those who regret the care they received. But I've also had the pleasure to speak with Maxine Heron, whose experience with puberty blockers was profoundly positive. Having the option to pause puberty spared her immense distress, and she has experienced no negative health outcomes. For her, being forced to undergo male puberty would have been the greater trauma. She is one of many who report their lives have been significantly improved by timely support. We must hold both kinds of stories with equal seriousness, I would suggest. Regret exists, but so does gratitude. The aim of research is not to erase one side story, but to understand why experiences differ, and crucially how best to help every child who is struggling. This is, Mr. Mundell, without doubt, one of the most challenging questions before us. How to protect young people, respect autonomy, and uphold scientific integrity. I, for one, do not pretend it's easy. I do hope that today's debate will help address some of the challenges and will reassure those who've signed the petition that their concerns are being taken seriously. I do know, and I can see with my own eyes, that many colleagues wish to contribute. I will therefore, Mr. Mundell, draw my remarks to a close, and I look forward to contributions in this debate, and especially the reply from the government, which I believe will be instructive. Thank you, Mr. Mundell.
Thank you, Mr. Stone. I remind members they should bob if they wish to be called in the debate. As the debate is heavily subscribed, I'm afraid that I will have to impose a 2-minute limit at the start, and that will not guarantee that everyone will be called. The question is that this House has considered e-petition 751836, and I call David Smith.
Thank you, Mr. Mundell. It's a pleasure to serve under your chairship. Any debate in which we're talking about the health and well-being of children and young people requires us all to be measured in our remarks, not least in the context of a debate that has been so toxic at times. Our focus in clinical studies and in any treatment we offer anyone, let alone children, should be first this: do no harm. And it's this axiom that seems to be the heart of the MHRA intervention that has paused the puberty blocker trial. To summarise where we've got to with the Pathways trial, parents are being asked to consent to a potentially life-altering intervention to their children in the absence of a life-threatening condition based on an unreliable diagnosis with an unknown trajectory. And so I urge the government to go one step further and cancel the trial altogether, not least because there are alternative approaches for us to establish the facts regarding the use of puberty blockers. And we do so with an approach that should be compassionate, understanding and holistic. The only question we should be asking in relation to gender dysphoria is, what is the best approach to support those that experience it? Dr. Cass, in her review, has said that the rationale for early puberty suppression remains unclear, with weak evidence regarding the impact on gender dysphoria, mental or psychosocial health. The effect on cognitive and psychosexual development remains unknown. And I would say within that context of a really good review that the Pathways trial was a mistake. I welcome the pause that has come in, but I would say that there is so much more that we can do that does not mean that we have to go for that. The MHRA has said that ultimately this puberty blockers can be very dangerous with regards to bone health, with regard to cognitive development, and with regard to the other long-term effects. So I would suggest that we must move from a pause in the trial to its cancellation altogether. There are other types of studies that we can do, not least the data linkage study that I would suggest that we focus on. Thank you, Mr. Mundell.
To time, which I'm sure Rebecca Paul will do as well.
Thank you, Chair. The use of puberty blockers on healthy children is deeply wrong. By giving these children these drugs, they are being locked into their discomfort and put on a one-way pathway to cross-sex hormones and surgeries. All of this leads to a lifetime of sexual impairment, fertility issues, bone density loss, and other catastrophic psychological and emotional impacts. No child put on puberty blockers at the earliest stage of puberty that has their natural puberty blocked will ever have an orgasm or be fertile. For anyone in this room cheerleading on this trial, that is what you are supporting. In December, the Health Secretary said at the dispatch box, and I quote, "Am I comfortable that this clinical trial has undergone the proper process and ethical approval to ensure the highest standards and supervision? Yes, I am comfortable about that." But then on the 20th of February, we found out that the MHRA had U-turned, raising serious concerns about the current trial. The issues they raised, however, were not new, having been raised by many in this room from the outset. Making children infertile and harming bone structure are not minor points of detail. They are fundamental safety flaws. This last-minute intervention raises questions about the rigour and diligence of the overall approval process. How did a trial with such potentially catastrophic health impacts make it through the Research Ethics Committee approval process? Having looked at the minutes of these meetings, I can see that members of this committee met 3 times over Zoom. 9 out of 12 attended the first, only 5 the second, and only 3 the third. What stands out most to me is the delegation of approval responsibilities by the REC to a subcommittee in the case of such a profoundly dangerous trial. Section 4.2.24 of the REC governance policy document indicates that subcommittees can be used when research proposals present no material ethical issues. I am therefore staggered that they took the decision to delegate approval responsibilities in this case. Thank you.
Called Josh Newbury.
Chair. At the outset, I want to acknowledge the strength of feeling that exists on all sides of this debate and our responsibility in this House to provide clarity, grounded in evidence and centred on the well-being of the young people we are talking about. This petition calls for the cancellation of the planned clinical trial of puberty-suppressing hormones, describing them as unsafe and inconsistently safeguarding. But the reality is that in part of her review, Dr. Cass was clear that we are lacking evidence and that one of the scenarios in which she believed puberty blockers should be prescribed for gender incongruence is a clinical trial. So a trial is a response to uncertainty focused on ensuring clinical decisions are made on a foundation of robust evidence. I have to say I find it a little more than ironic that when the Cass review was published, many of the same voices telling us that a trial should now not go ahead were saying that the Cass review should be accepted and implemented in full. They've gone from saying we need the evidence to this trial should be stopped. But if someone could show me another way of properly gathering clinical evidence other than a full clinical trial, then I'm all ears. But in reality, what we're talking about here is shutting down options for trans people. With waiting times for a first appointment for a gender identity service currently standing in many cases at more than 5 years, it's not as if there are copious alternatives out there for this group of young people, many awaiting the entirety of their adolescence just to start treatment. Would we tolerate that in any other group of patients? I doubt it. So whilst I respect... in the interest of time, I won't. So whilst I respect the concerns that have led many to sign this petition, I'd urge colleagues to reflect on the consequences of the course of action it proposes. Cancelling research does not resolve uncertainty, it entrenches it. In doing so, it risks leaving vulnerable young people without the evidence base needed to support safe, informed and compassionate care. As someone who is proud to be an ally of the trans community, I believe we have a duty to ensure trans young people hear a clear message from this House that they are supported, respected, cared for and never alone.
Rosie Duffield.
Thank you, Mr. Mandel. Serve under your chairship. Firstly, it's important to acknowledge that having been steeped in this issue for many years now, I know James Esses, the therapist over there who organised this petition, who, along with formidable Kira Bell and the Bayswater Support Group, have managed to halt this trial. So no children are currently being recruited until the High Court makes that decision, probably until at least July. It's clear that what we're talking about is an extremely vulnerable cohort of children. Recently, James told MPs and peers here that first and foremost, most of his patients, almost all of them, are autistic. As recognised by the Cass Review, children and adolescents on the autism spectrum experience difficulties with social belonging and can be particularly sensitive to seeking affirmation from others. James explained to us that many of his patients rely on rigid and regressive stereotypes, including the tropes that a preference for activities or even friendships traditionally associated with the opposite sex must mean that they actually are that sex. This, of course, is the basic foundation for the so-called gender-critical movement, a rejection of labelling, pigeonholing or aggressive stereotyping of what constitutes boy or girl behaviours, clothes preferences or activities. For over 20 years, medical professionals raising their sound judgments and concern about ethics and child safeguarding at the Tavistock have been ignored, their concerns buried and themselves punished, sidelined and vilified. For challenging an entirely ideological project, it's thanks to medical professionals such as Sue and Marcus Evans, Dr David Taylor, Dr David Bell and Sonia Appleby, to name just a few brave medics, and the committed reporting of journalists such as Hannah Barnes and Julie Bindle, that we are having this debate today. In all of the years I've been actively campaigning against the impossible notion that anyone is born in the wrong body, I've been labelled far-right, bigoted, transphobic, and all kinds of other ridiculous slurs that would be unparliamentary to repeat here. We must stop this trial because they're an incredibly vulnerable cohort of children as young as 12 who cannot possibly give consent.
I call Jonathan Hinder.
Thank you, Mr Mundell, and it's a pleasure to serve under your chairmanship today. The proposed puberty blockers trial on children is not just badly designed, it is profoundly unethical. It proposes that vulnerable children struggling with their identity but medically healthy be given drugs which risk permanent damage. This group of children are deeply vulnerable, we know that. They deserve proper care and treatment. But actually the medicalising of gender identity risks underlying conditions being overlooked, meaning children do not get the support they really need. Children in this trial would be at what is called Tanner Stage 2 of puberty. For children at Tanner Stage 2 who proceed to cross-sex hormones, and that is basically all of them, infertility is not a risk but is an expected outcome. I repeat, once you are locked into this medicalised pathway, infertility is expected. So let's be absolutely clear about what this trial would mean. The British state sterilising healthy little children in plain sight, not by accident, but consciously and deliberately. How could we do this to children? It would be the most appalling state scandal you could imagine. These medically healthy children need love, they need compassion, they need support, but they should not be given powerful drugs to stop their body from developing as normal. The truth is that puberty can be very distressing for any child, not least those who do not conform to regressive gender stereotypes or those who will grow up to be same-sex attracted. Puberty is a natural and essential part of becoming a fully grown human being. So I say to those children, you are perfect just the way you are, and you do not need to be somehow corrected with these drugs. Children of primary school age cannot possibly give consent to these life-changing decisions, and when they become adults, many of them will look back on what was done to them and ask, how did this happen to me? How did the government do this to me? Thank you.
I call Carla Denyer.
Thank you, Mr Mundell. It's a pleasure to serve under your chairship. As an MP, I hear far too often from young trans and gender questioning people and their families who are unable to get the treatment that they need. It's important in this debate to start by being really clear what puberty blockers are and are not. They do not, on their own, make any permanent changes to a young person's gender. Some people who start on puberty blockers, yes, will then go on to further treatment, some will not. What puberty blockers can do is give young people time to explore their gender without the added distress of unwanted physical changes. That gives them the time and space to decide if they want to take more permanent steps. Puberty blockers alone do not lock young people into any permanent decision. Now, new prescriptions for puberty blockers have been indefinitely banned since November 2024, meaning that the Pathways trial has been the only legal way to get a prescription. The Green Party opposes that ban on puberty blockers and always has, because they're a safe and reversible way of reducing gender dysphoria that's recognised by international research and advisory bodies. The list is honestly too long to give in the time we have here, but it includes the European Society of Paediatric Endocrinology, the American Association of Clinical Endocrinologists, the European Society of Sexual Medicine, and so on. My concern is that the Pathways trial has been paused, not because of a genuine concern about young people's safety, nor because the government has listened to the constructive concerns from the trans community about how the trial is going to be run. My concern is that the pause looks like a political decision. Now, if further research on puberty blockers is needed, and I understand that most medical treatments benefit from ongoing research, then that research must be carried out in a way that does not exclude or disadvantage one patient cohort over others. So it should centre the needs of those young people. There should not be a cap on participants or an unmedicated control group, and it should take account of all uses of puberty blockers, that is, including on cis children experiencing premature puberty as well. We so often talk about trans people without including them in decisions made about them. I ask the Minister to reconsider the government's path here.
Dr Scott Arthur.
Thank you, Chair. So I do believe that a trial for puberty blockers is necessary, and I'm hopeful that the issues raised between the MHRA and King's College can be resolved in this case to allow the Pathways trial to go ahead. If not, I hope an alternative trial can be proposed. I believe that if you accept trans people exist and have rights, which I think, or at least hope, everyone here does, then trials like this are a natural consequence. I do understand the concerns people here and outside this place have about the long-term medical impacts of puberty blockers. This is why we should act cautiously, and it's why a trial is needed. We cannot possibly understand these short or long-term impacts without studying puberty blockers properly. This trial came about because of a lack of conclusive evidence on the use of these drugs. The answer to this is not to allow their legal use again, but to undertake a trial into both their benefits and also their consequences. Not long ago in my constituency, I met the parents of a trans woman. Their daughter struggled significantly with her mental health during her teenage years, and at one point was hospitalised due to severe eating disorder complications. And these were driven by her decision to reduce her calorie intake because she thought that would delay puberty. Her parents have told me that they believe a big cause of her issues was her inability to express a true gender identity, and they have no doubt that puberty blockers would have saved her from some of the anguish she has experienced. While I know life is not always easy for her, my constituent's daughter has since medically and socially transitioned and lives openly as a woman and is happier as a result. This story shows the profound impact that a struggle with gender identity can have on a young person. And I have to say, I think it's offensive to talk about these young people simply needing love, about trials being experiments, or suggesting that this would be an impulsive decision by anyone. People talk about trying to have moderated language. I think we have a duty to bring people together on this topic, not create division. Thank you, Chair.
Tugendhat.
Thank you, Mr. Mundell. I think we should start off by recognising that the life choices that adults make, in whatever way they make them, are to be respected and not to be criticised in any way. This is not in any way a criticism of anybody who chooses a trans identity or who identifies as trans or who chooses any other identity or identifies in any other way. This is simply about the experimentation on children. Now, let's be absolutely clear. We would not tolerate any form of medical experimentation on children in such an uncertain category with any other treatment. And we would, quite rightly, put forward the Hippocratic Oath of to do no harm. So to change that, particularly on a group of children who are, by very definition, most often already suffering from some other element of potential harm, including, as one of our honourable members mentioned, autism, would be to victimise, or rather to re-victimise, children who are already vulnerable. Now, that's where this has got to be so delicately treated and so carefully treated, because the truth is this is getting wrapped up in identity politics. It's being played with politically by those who wish to, as it were, advertise their own progressive credentials, forgetting that this is very fundamentally about one thing. It is about the protection of children. Now, whatever... I won't give way. Now, whatever the views are of those people in this room and those honourable members who also are going to speak, there is a second element that this government really must consider. Because we are already, quite rightly, seeing honourable individuals like Kira Bell who have raised the problem of detransitioning and possibly the legislation, or rather the legal costs of their actions against the state. What money has the government set aside for legal action for those who are, by definition, too young to consent because they are not 18 years old, and by definition are therefore able to bring legal action against the state for any experimentation that was done on them, as would have been in this circumstance? Thank you.
Emily Darlington.
Thank you, Mr. Mundell, and it's a pleasure to serve under your chairmanship. I want to start first with this expression, do no harm. I want to be clear that people that have come to speak to me, parents and young people themselves, we are doing them harm by not giving them the treatment they need, the wait times of 6 years, and potentially puberty blockers where that is agreed with their healthcare professionals. But my overarching concern is this clinical trial was suggested in the CAS review. It was proposed in conjunction and designed in conjunction with the MHRA. and then the MHRA changed their mind. Now, why is that? Dr. Hilary Cass said, "There's no new research findings and the MHRA hasn't presented any new evidence. It feels to me like they're responding to political pressure rather than to science." Now, this is what she said. I'm quoting her verbatim, and it's her review that people around this chamber wanted us to listen to and make changes in responding to. So I think we have to listen to her in this case as well. The MHRA should be without any political interference or fear of legal action. The MHRA itself referenced potential legal action in relation to this trial as one of the reasons it had changed its mind. This is a problem. The MHRA is there to make sure that anything from clinical trials, medical technologies and new drugs is absolutely done on the basis of science and science alone. Sure.
I thank the Honourable lady for giving way. The problem is that the Professor George, at the lead of the MHRA, is actually being hounded and scapegoated after recusing himself. And it's really, really sad to see someone in such a professional situation. So I would urge her caution with some of the words, because he recused himself. He was not, I would just like to say he is a great man who's being hounded.
Look, I am not for hounding any particular individual, and the only person I have referred to by name is Hilary Cass, and she's been on the public record. I have been hounded for my views as well. Everybody, exactly. I'm not, and I think that's completely inappropriate. There was a leader of a political party that shouted traitor at me when I said we should watch our language around this issue. Now, I don't know who they think I'm a traitor to, but certainly not to the human race. You say you've got death threats. I get death threats too. This is not unique to you, Rosie. Oh, sorry, to the Honourable Member. And quite frankly, sorry, I apologise for that. I shouldn't have used your first name. The reality is the MHRA should not be an environment where it has any fear from any legal action. It should only look at the science, and anybody who feels that many of the community feel that this trial has now become too political for anybody to touch. Yeah. And we've forgotten about those children where, quite frankly, if we don't do anything, we are doing them harm.
I call Carla Lockhart.
Not experimentation. In Upper Bann alone, 1,300 people signed this petition, more than twice the number of any other constituency. Their message is clear, and I stand with them. Animal testing on mice and monkeys show that puberty blockers cause irreversible damage to brain development. If these hormones are unfit for animals, why on earth are we about to inject them into our children? Children are once again being used as lab rats for a dangerous medical experiment. It is wrong. We should not be experimenting on a fresh cohort. Instead, we should be prioritising a data linkage study of the hundreds of children who were given puberty blockers at the now discredited and closed Tavistock Clinic. It is reckless to allow minors to take certain risks while they are still maturing. All participants will be under 16. We do not allow these teenagers to drive, get married, buy alcohol or own a gun. We should not be putting them on a medical pathway with such life-altering consequences. In fact, for most children who are questioning their gender, going through puberty will naturally resolve their gender dysphoria. We should be offering vulnerable young people support and stability, not giving them life-altering drugs. We also should send a shiver down our spine when we look at the documentation around the safeguarding. Participants are warned against getting pregnant while taking puberty blockers. There's no mention of the fact that the legal age of consent is 16. Even more concerningly, girls will be advised to consider getting their eggs harvested, normally a procedure for IVF or cancer treatment. Complications include ovarian hyperstimulation syndrome, which can cause severe abdominal pain and even death. There's no mention of these risks in the document. I have personally met Ciara Bell. She is sounding the alarm for anyone who will listen. Doctors did not give her holistic care. Instead, they affirmed her false belief that hasty medical intervention was the answer. I and my constituents say we need a total ban, not just a temporary pause to this dystopian medical trial.
Rachel Taylor.
Thank you, Mr. Manzella. It's a pleasure to serve under your chairmanship. Over the past year, the public debate has often become heated, personal and at times deeply harmful. That rhetoric has consequences, and we in this House must take responsibility for the climate that we helped to create. The recommendations of the CAS review were so important. Amongst them was a clear call for carefully designed clinical trials to build the evidence base around puberty blockers, trials that would allow clinicians, patients and families to make informed decisions, grounded in robust data rather than speculation or ideology. Those who argued that puberty blockers should be restricted due to insufficient evidence are now opposing the very research that would provide that evidence. That does not suggest a commitment to scientific rigour. It suggests a shifting position, driven by political ideology. I'm not a clinician, and I don't pretend to be. On matters such as these, we must be guided by medical evidence.
Would you give way?
No, I won't give way for the sake of time. That's precisely why the current situation is so troubling. It's concerning that the MHRA initially raised no objections to the trial when it was approved, but it's since changed its position. As Dr. Cass made clear, no new evidence has been presented to justify this shift. This raises serious questions about the basis for the decision. It raises the question of whether an independent regulator has buckled to pressure from a well-funded lobbying campaign. The consequence is that vital research is now at risk, and that matters because these trials are not an optional extra. They're the mechanism through which we build the evidence base that critics say is lacking. We cannot afford, no, I'm not giving way, we cannot afford to sacrifice the future of vulnerable young people on the altar of ideology. These trials received ethical approval. They were recommended by one of the country's foremost experts in child health. It's vital they go ahead so that we can build the evidence we need to support safe, effective health care for young trans people.
Sarah Poacham.
Thank you, Mr. Mundell. It's a pleasure to serve under your chairmanship. I concern myself with the motivation behind these trials. I went to the initial meeting when we met the panel of so-called experts hosted by Wes Streeting, and I came away with the impression that this was nothing more than a spine-chilling, state-sponsored experiment on our children with no regard to the safeguarding of those children. And what I also asked for in the chamber of Wes Streeting was that he introduces statutory legislation to access the extensive data that is already available from Tavistock, and yet, again, I was not provided with an answer as to why he couldn't do that. I'm concerned about the profile of the children being used. I asked at that initial meeting for a lower age limit. I was refused. I asked if they would consider not including vulnerable children, children in care, children on drugs for anxiety, ADHD. We were refused. We've all talked about the long-term damage that seems to be ignored. But one of the most important things that hasn't really been covered is parental consent. We've heard that only one parent needed to consent where there was a parent present in a child's life. That will damage irreversible damage to families that can cause. And I hosted a round table last week about the indoctrination of our children in schools on this very subject and heard horrific stories from isolated parents whose children were lost to them because of brainwashing and the fantasy world that they've been taught in school. No, I won't. And finally, overall, we are creating a generation of lost, anxious young people confused about their identity, socially insecure and physically scarred.
Alex Sopel.
Many of my constituents have spoken to me and written to me anxious about the trial and the pausing of the trial. And the word of one of my constituents, to be a true ally, you must support all trans people and their needs, not just adults. As a matter of principle, politicians should not meddle in medical decisions. If we accept that trans people exist, if they are to be accepted, they need to have access to health care. We must listen to the experiences of trans young people and take action to protect their well-being by opposing restrictions on gender-affirming care for trans youth. All children need access to safe and timely health care in line with international best practice. The pausing of this trial is causing deep anxiety amongst many of my constituents. International best practice, as laid out by the World Professional Association of Transgender Health Standards, emphasise decisions around hormones should be made on a case-by-case basis. Puberty-suppressing hormones have long been used by children experiencing early-onset puberty, and significant international research and advisory bodies already support their use by trans adolescents, safe, reversible means of alleviating gender dysphoria and improving psychological functioning and well-being. They're used in Canada, Belgium, Netherlands, and many other European countries. I've got 4 asks of the Minister: that the Department has legitimate engagement with the widest range of advocacy groups, including groups like Transactual, and to understand the real human impact of the ban and ensure that future policy is informed by those directly affected. To reinstate the trial while ensuring those who do not wish to partake in research can continue to access appropriate health care. Revise their policy and prescription of gender-affirming hormones to remove arbitrary age limits in line with international best practice, and to do more to bring down the waiting list, which are more than 6 years from first appointment to young person's gender service. Like many, I'm concerned about the erasure of the trans community, and we need to heed many arguments that they are making today. In the words of the trans community, nothing about us without us.
Yeah. Joy Morrissey.
Pleasure serving under your chairmanship. And the truth is, this clinical trial is flawed, and we should not be experimenting on children. I believe that we should be protecting children from many harms, such as alcohol, nicotine, the age of consent for sexual intercourse, and also for marriage. We have those things to protect children. And it's important to remember that children's prefrontal cortex does not develop until their mid-20s. So even their ability to grasp the long-term effects of any decision is limited. And whilst the diagnosis for this trial is necessary, it is not sufficient in determining whether medical intervention should take place. Cass directly makes this point, and I quote, "Although a diagnosis of gender dysphoria has been seen as necessary for initiating medical treatment, it is not reliably predictive of whether that young person will have long-standing gender incongruence in the future, or whether medical intervention will be the best option for them. The Pathway trial uses ICD-11 diagnosis of gender incongruence, which simply requires a desire to transition. The diagnosis is subjective, based on how the child feels. Can the long-term risk of medical intervention be justified by such a vague diagnosis? If the core diagnostic tool cannot predict outcomes with confidence, this trial would expose children to harm without a sound basis for believing that the medical intervention is in their best interest. The trial has been framed as a pathway to clarity, yet it is flawed before it has even begun, and so proceeding is not neutrality, but a decision with consequences. This trial would see harmful, long-term, and irreversible damage to children and should be cancelled."
Iqbal Mohammed.
Thank you, Mr. Mondale. It's a pleasure to serve under your chairship. This is a government that's shown that it cares for the safety and welfare of children. This is a government that supported the Online Safety Act to counteract harmful digital content. This is a government that, albeit eventually remove the punitive two-child benefit cap to reduce poverty. This is a government that is committed to halving violence against women and girls. And this is a government that has banned junk food TV advertising pre-watershed. However, this trial flies in the face of this government's stated explicit mission to protect children from harm. It would expose children to severe and irreversible harm when viable, less harmful alternatives are available. Yet despite that, it is happy to permit a clinical trial that would give these very puberty blockers to 226 children. Research has reported that children who start out on puberty blockers, over 95% of them continue on to cross-sex hormones. But other research has also shown that between 60 and 98% of children with gender dysphoria will outgrow that feeling, and they will go on to live a normal, natural, healthy life in their born body. So what this government is doing is that I'm going to continue due to the lack of time. So the numbers are important. This would mean that the government is choosing to prioritise the interests of between 5 and 90 of those 226 children involved in the clinical trial at the expense of deliberately harming between 135 and 203 children that will eventually come to terms with their birth sex. So my ask to the Minister, will the Government now confirm that the current pause, which I welcome and I'm grateful to the Government for, will remain in place unless and until all safety, ethical and scientific concerns are fully and transparently resolved?
Jim Alliston.
As politicians, we all profess that we are interested in protecting the vulnerable. Well, if we are, surely one of the most vulnerable age ranges in our society are those going through adolescence. And therefore, if ever there's a need for protection, it is the adolescents that we need to protect. Feelings and behaviours fluctuate during adolescence. That is, I'm sure, the experience of us all as parents, etc. And so gender dysphoria, more often than not, resolves naturally during puberty. That's the reality. And yet, for too long in our society, we've had this laissez-faire attitude to puberty blockers. Until 2024, no restraint whatsoever. And the question that I raise is, what was the damage done to those children before this pause was imposed? Does no one care about the damage that was done to those children? Because it is, whether one likes the word or not, experimentation on children. And experimentation without a due process of consent. It is incapable of having a due process of consent. And therefore, when we endorse puberty blockers, we are turning a blind eye to the fact it might have medical consequences on their bone density. It might have medical consequences on the development of their brains. Do we not care about that? If we care about that, then we need to cancel, not just pause, this programme.
Rebecca Smith.
Thank you, Mr. President, under your chairmanship. Now, I have strong concerns about artificially delaying puberty, but at the same time, I want to see high-quality, holistic support for young people who are questioning their gender. Now, the CAS review recommended psychological care as the first port of call for managing gender distress, yet this NHS trial shows a worrying bias towards medicalisation. As a former corporate parent, I am alarmed that looked after children were overrepresented in referrals to the NHS Gender Identity Development Service. They made up just under 0.6% of the general population at the time, but 5.9% of referrals. For children in care, the transition to adulthood is already a challenging time. They are often more vulnerable to the suggestion that puberty blockers could solve their problems. Despite this, children in care will still be allowed to enrol in any trial. Who will consent to their treatment? Why the state itself, represented by a corporate parenting board. This, in my belief, blurs the line between child safeguarding and institutional interest. The state is wearing two hats, legal guardian and trial sponsor. Another serious issue is that this trial risks treating young lesbians as if they are born in the wrong body. Shortly before GIDS closed down, 74% of teenagers referred to the clinic were girls, most identified as lesbian or bisexual. Almost 70% said that they were attracted only to other girls, and 20% were attracted to both sexes. Yet in recent years, some young women have been encouraged to identify as trans rather than lesbian, and it's my view that this trial will only reinforce this belief. Lastly, we know that at least 64 patients from the Tavistock Clinic have returned to living as their birth sex between 2010 and 2020. Detransitioners face huge social pressure to stay silent about their experiences. So I want to conclude by quoting the brave detransitioner Kira Bell. She says, "The state assisted me in destroying my body during a period of distress. I was a tomboy who came out of an abusive, neglectful environment with a lack of positive role models, and I struggled with my sexuality. Stopping children's brains and bodies from developing is not a solution, nor is it healthcare." It's like giving a Zimpec to an anorexic or alcohol to an alcoholic. We need a permanent end to this trial, not just a pause. Otherwise, even more young people will be left asking the same question, why did no one stop me?
And our final backbench contribution from Gregory Stafford.
Thank you very much, Mr Mundell. It's a pleasure to serve under your chairmanship. My constituents across my Farnham and Borden constituency have a clear expectation that we proceed with caution when it comes to children's health care. But there is a fundamental contradiction at the heart of this trial. The government has already restricted these drugs due to what it described as an unacceptable safety risk. Yet those same drugs are now being made available through a clinical trial. We must also look squarely at the evidence. There is no robust proof that puberty blockers deliver the benefits often claimed. In fact, the evidence suggests that for many children, gender-related distress resolves naturally through puberty. The risks, however, are very real. Bone density, brain development, fertility. There are also serious ethical concerns. We are talking about administering powerful drugs to young children with no reliable way to predict who will benefit. This is not a targeted intervention, it is a gamble, and it is a gamble with children's future. The design of the trial only adds to those concerns. It compares immediate treatment with delayed treatment, rather than examining long-term outcomes, and relies heavily on subjective measures rather than clinical evidence. It risks answering the wrong questions while exposing children to the well-rehearsed risks. Even more concerning is the sequencing. Clearly, we should understand past outcomes first, yet the trial presses ahead before them. The process itself also gives us pause. This trial received ethical approval and £10.7 million of public funding, yet within months it's been paused following intervention by the regulator over concerns about safety and design. If a trial collapses under scrutiny before it begins, that tells us it's not ready, and it raises a serious question about why it was pushed forward in the first place. Before I conclude then, I urge the Minister to explain why, given the known risks, the trial should proceed at all. Mr Mundell, when the evidence is weak, the risks are real, and the patients are children, pressing ahead is not leadership, it's recklessness.
I now call Helen Morgan to speak on behalf of the Liberal Democrats.
Thank you very much, Mr Mundell. It's a pleasure to serve with you in the chair. And can I start by thanking my honourable friend, the member for Caithness, Sutherland and Easter Ross, for his opening speech and the compassion and balanced nature with which he introduced this debate. Now, Liberal Democrats have been arguing for many years that improved access to better specialist healthcare services for children and young people struggling with their gender identity is extremely important. These young people have been badly let down by low care standards, extremely long waiting lists, and an unacceptably toxic public debate. Now, up front, I want to be clear that my party's position is that any treatment and the approval of a trial must always be led by clinical expert evidence and not by personal belief, however sincerely that belief is held. For these reasons, we welcomed the call in the CAS review for a clinical trial and continue to do so. Now, following the closure of the GIDS clinic, which was rated inadequate by the Care Quality Commission, it's clear that change is needed. Under the previous system, over 5,000 young people were stuck on a waiting list for a single clinic, each waiting an average of 3 years for just their first appointment. We've consistently campaigned for real action to tackle the shocking waiting times across the NHS, whether that's from cancer patients to mental health referrals, and the importance in cutting these wait times is equally pressing for gender identity services. We've been pressing for new services with more specialist clinicians who can provide children and young people with the appropriate and high-quality care that they need. Liberal Democrats welcome the NHS move to create new regional centres to offer this healthcare to the young people who need it. However, as far as I'm aware, so far only 2 have opened, one in London and one in the North West, and we would like to hear confirmation of when further centres will open. Young people who are stuck on these waiting lists will still have to wait a very long time, and at such a distressing point in their life, the average 3-year wait for someone to see a specialist must feel like an eternity for them and their family. The government must show true urgency in opening these centres to prevent more children from being further denied the care that they need. Now, it's right that treatment should firstly be based on talking therapies. This gives those receiving treatment and their families the time, space and clarity to make informed decisions about their future. However, young people must therefore be able to start talking therapy when they need it as a matter of urgency, not after languishing for years on waiting lists. Now, following the CAS review, the Secretary of State announced the launch of an NHS clinical trial to investigate the impact of puberty blockers, alongside an indefinite ban on puberty blockers as treatment for gender dysphoria or gender incongruence, and that trial has now been paused. It's absolutely crucial that decisions on treatments are made by expert clinicians and based on the best possible evidence. But we need the NHS to build up that evidence base effectively and safely. In this vein, we're supportive of the Secretary of State's decision to pause the trial while the concerns raised by the MHRA are thoroughly assessed. I'm calling on the Government to publish how the MHRA arrived at its decision to pause the trial so there can be confidence that the decision was led by clinical evidence. As with any medical treatment, it's crucial that decisions are led by expert clinicians following the evidence on safety and effectiveness. Research should also take into account the personal experiences of those who've previously used these services. This debate should not be an ideological one. It is a debate about the quality of healthcare we provide to people who are in desperate need. All trans and non-binary people should be able to access the high-quality healthcare they deserve. Liberal Democrats call on the Government to make tackling these unacceptable waiting times a priority. To take the urgent action that is needed, the Government must commit to NHS child and adult services for trans and non-binary people that will expand the timely provision of appropriate specialist healthcare. Ensure trans people can access high-quality healthcare in the manner we expect for all patients. Medical decisions should be made by patients and doctors together and informed by the best possible evidence. Support research through effective and safe methods using international best practice to improve our evidence about the safety and efficacy of potential treatments. One thing is certain. In a debate where the well-being of very many vulnerable young people is at risk, decisions should not be led by ideology. We cannot let a toxic public debate threaten the well-being of vulnerable individuals. The Government must prioritise clinical evidence and put the interests of patients at the heart of the decision-making process, as we do in all areas of healthcare. Thank you.
Minister Dr Caroline Johnson.
Thank you, Mr Mundell. It's a pleasure to serve under your chairmanship this afternoon. I must declare an interest first as an NHS consultant paediatrician. I'd like to thank James Esses for this petition and the thousands of people who've signed it, including many of my constituents, for enabling this important debate today. I'd also like to thank my honourable friend from Caithness, Sutherland and Easter Ross for leading the debate so well. The petition asks the Government to cancel the puberty blockers trial and to safeguard vulnerable children. Perhaps, Chair, it's worth considering whether, in principle, clinical trials in children are a good idea. The answer, of course, is yes. Children are not just small adults. They have different illnesses to adults. They present with different symptoms and respond differently to medication. They require different doses at different ages. Properly designed clinical trials ensure children's medicines are safe and effective for them. But today, Chair, we're discussing one particular trial, a proposal to give puberty blockers, gonadotropin-releasing hormone analogues, to children specifically for gender incongruence. So perhaps at this point it's worth considering why doctors and others prescribe medication. We do it to treat or cure disease, to treat or lessen symptoms, and to aid in diagnosis. And what does this trial seek to do? On the face of it, it seeks to establish whether puberty blockers are a safe and effective treatment for gender incongruence. ICD-11 defines gender incongruence as a marked and persistent incongruence between an individual's experienced gender and their assigned sex. To suggest persistent incongruence with gender stereotypes is wrong, could undo years or decades of rolling back gender norms. And if it is not causing the person any distress, why would we want to treat it? Especially when we know that most children, even those with gender dysphoria and who do have distress, will get better without any puberty blockers. Currently, there is no way to identify which children will persist with the trans identity as adults and which will not. The much-delayed data linkage study could help with this. It could enable more targeted interventions. It may also provide information on the long-term outcomes for people who've taken puberty blockers in the past. But the Government insists on pushing on with this puberty blockers trial anyway, before the data linkage study is complete. Why? In written parliamentary questions, ministers have said they expect the data linkage study to be finished by April 2027. So what is the rush? And what is the point of the treatment? It has been suggested that it helps transgender adults pass more easily as the opposite sex and potentially avoid surgical operations in adulthood. But, Chair, how on earth can it be ethically, morally or medically right to treat a large group of children with risky medication to give cosmetic benefits to a much smaller number of adults? And there are cosmetic risks to the treatment as well. The penis grows very little between the ages of 3 and 10 years. The use of puberty blockers restricts growth, meaning those with a persistent trans identity may struggle with enough tissue for a vaginoplasty surgery, and those who don't have persistent trans identity may struggle with normal intimate relationships. The Secretary of State, as has been said earlier, said he has confidence in this trial. Now it's been paused, we can presume that he's not quite so sure. But can we, can patients, and can the general public have confidence in this trial? There is certainly cause for concern. In fact, there are so many, I can't speak of them all today, but I'd like to speak of a few in the time I have available. Firstly, the selection of patients. We've had a dramatic change in the demographic. There have always been some children, a small number of children, uncomfortable in their own body, but there has been a rapid increase, which is not fully understood, particularly amongst girls. Many of them are in care, some have autistic spectrum disorders, many are same-sex attracted. We need to understand this before prescribing reversible treatments. We do, and I have, prescribed drugs which are high risk or potentially harmful to children. An easy example would be chemotherapy. But that's being given to save a child's life. It's not being used to pause a perfectly normal physiological process in a physically healthy child. The risks of these treatments have been listed today, but I'll list just a few. Fertility problems, idiopathic intracranial hypertension, demineralisation of bone density leading to fractures. In some studies, an increase of depression and anxiety, and long-term loss of sexual function in some patients. We've discussed consent. How do you get consent from a parent of a child, a boy or girl aged TANA stage 2, about long-term sexual function and fertility? The design itself. It's a randomised controlled trial. Well, it is, but it's a bit of a fudge. Because instead of an actual randomised controlled trial where some patients received puberty blockers and some patients did not, they've given some now and some slightly later, with a very short period of time. The comparison group they're using that doesn't have any puberty blockers at all is taken from a slightly different population. This introduces a bias that's not necessary. The trial's organisers have said that they're doing it because they think the children would get the drugs from elsewhere or from abroad. But that's not how we do medical trials. When I've raised this issue, ministers have responded that it cannot be blinded. But blinded and randomisation are not the same thing. It's also far too short to provide long-term outcome data. The process of it. The member for Gower raised questions about the questions that are being asked to children as part of this trial. But why is the trial proposing to ask children about their sexual experiences? Why is this helpful to the trial? The Commission on Human Medicine's report heard that because puberty blocker trials have been blocked, I won't because I'm aware of the time, but thank you. Puberty blocker drugs have been blocked. Some clinicians are trying to use other drugs to limit puberty, such as spironolactone and cytoprotein acetate. There have been reports that the number of prescriptions for spironolactone in 10 to 17-year-olds is going up. Could the Minister confirm this is the case and what the government is doing to look into this? The MHRA was happy with the process. Now it's not. What's changed? None of the issues that were being raised seem to have been not raised before, and they're being secretive about it. The ministers brought forward in February a written statement referencing an MHRA letter in November, but ministers are refusing to publish it. I've asked ministers if they've talked to MHRA officials about the trial before February 26, and they won't answer the question. There was a letter between the MHRA and KCL. I asked when it was received. I asked when the ministry became aware of it, and when they became aware of its contents, and they won't tell me. What about the people controlling the trial? As has also been reported during this debate, Professor Jacob George has been recused from further involvement. According to the MHRA statement, this is a precaution because of social media posts made before his involvement. Why have those who made the opposite type of comment not been recused too? It will inevitably make the members of the public think there's bias involved. There is an oversight board. What has the Minister done to see that the clinicians and scientists on that board are impartial and that it's balanced between both perspectives? The Tavistock trial was supposed to report to the MHRA, and it didn't, seemingly with no consequence. There will be lay members on this committee with lived experience. Will one of those be a detransitioner, or will they all be from people on one side? This will increase the perception of bias in this trial. In summary, Chair, this is a trial of risky medication on healthy children, most of whom's features of gender incongruence will resolve given normal puberty in time. And what is particularly worrying is that at the end of this treatment, the trial has so many flaws that whatever the result is, it is bound to be disputed. The leading clinician, in order to give this treatment, will need to think there is a reasonable prospect of the patients getting benefits from puberty blockers. Given all that has been said, how can any clinician believe that that is the case? I hope, Chair, that we can all agree that we don't need a clinical trial to know that helping a child to be at peace with themselves and their body is infinitely preferable to a lifetime of harmful medical intervention.
Minister Karen Smith.
Mr Mandel, it's a pleasure to serve under your chairship. And can I also thank the Honourable Member for Caithness, Southern and Easter Roche for, and indeed the Petitions Committee, and for the way in which he introduced this debate and in his usual style made sure that he talked to a range of people and experts in order to be able to inform this debate. And I do want to start by recognising the thousands of signatures on the petition show the real strength of feeling on this issue, and thank everyone for taking part. And I am acutely conscious of that in terms of the young people, their families, and people in the gallery here today and outside who are paying close attention to this debate and what has been said. And I hope to address all the issues that have been raised. I have been keeping careful notes and listening very carefully. I pretty much think I am addressing all of those issues, and I know people want to get this on the record. I'll say now I'm not going to take any further interventions, and I'm just going to set out where I think we are, and where there aren't particular questions I pick up, I'm going to get back to people. So I want to really assure colleagues and the signature of the position, particularly young people and their families, that particularly those who are waiting for, have had or been concerned about gender services, this government will always be led by science and not ideology. And we are proceeding carefully in line with clinical advice, and we will always put the interests of vulnerable children first, because their health and their well-being are not negotiable. That's our position. So let me start by beginning briefly on some of the context. In 2020, NHS England commissioned Dr Hilary Cass to undertake the review of NHS children's and young people's gender services. And I'm sure, like others, I've taken time over the weekend, Mr Mandel, to read both her interim report, to reread her interim report, and reread the full report. And I do commend both of those reports to people with interest in this subject. Dr Cass is one of the most preeminent clinicians in her field, and her review is the most definitive assessment of its kind, and it laid bare the inadequacies of the now decommissioned Tavistock Gender Identity Development Service. The interim review and the final report made clear that we needed better data and a stronger evidence base to design the right services for children and young people presenting with questions around gender dysphoria or gender incongruence, given the poor evidence base for services and treatment against rapidly increasing, and we've heard, changing demand. She recommended a new model of care based on holistic assessment and psychosocial support and further research into puberty blockers, specifically where they're not provided in isolation. And we welcomed her report as the Labour Party in opposition and accept her findings in opposition and continue to do so in government. Now, there are many recommendations in her reports that are being implemented, including opening new NHS children and young people's gender services, while building the evidence base in parallel through a national research programme. So with respect to the trial, as Mr Stone has outlined, the rationale for the clinical trial is part of those recommendations in order to gather robust, contemporary and comparative evidence on the relative benefits and harms of puberty-suppressing treatments in children. That's the way that we can decide whether or not puberty suppression can be an option within NHS gender care in the future. The Pathways trial has undergone thorough scientific, clinical, ethical and regulatory safeguards, and following the academic peer review, it was supported by the independent National Institute for Health and Care Research Funding Committee. It was endorsed by a multidisciplinary and multi-agency National Research Oversight Board, and it was then subject to formal regulatory approvals via the Medicine and Healthcare Products Regulatory Agency, known as the MHRA, the Health Research Authority, the HRA, including a review by an independent research ethics committee, and finally the Commission on Human Medicines, who made considered recommendations to the study team that were adopted in full. Now, as with all complex clinical trials, the top priority of each of these organisations is the safety of the trial participants. The MHRA in particular is maintaining a high level of scrutiny and taking a cautious and measured approach. And where appropriate, after initial approvals have been granted, there can be ongoing dialogue between the sponsors of clinical trials and the MHRA. That is part of the process, and I really want to stress that point. The MHRA have raised some concerns relating to some elements of the trial designs, and those questions obviously need answering. Rigorous and constructive discussions are accordingly underway between the MHRA and the trial sponsors. Now, Mr Stone, the safety and well-being of children, I'm not going to give way, I'm going to get through these points. Mr Stone, the safety and well-being of children and young people have always been the driving consideration in every decision we've made regarding this trial, and they always will be. That is why the trial sponsor has paused recruiting until these issues can be resolved. So I know today I've had calls for cancelling the pause and continuing with the pause and cancelling the trial, but that is the position. It is paused until the issues are resolved, because we will not compromise an inch on safety, and the trial will only proceed if the regulatory approval is reconfirmed, and we will update on the outcome of those discussions as soon as we can. Dr Cass also recommended, I'm going to go on to the data linkage study. Dr Cass also... Thank you, Mr Mundell. Dr Cass also recommended we take forward the data linkage study as part of the wider national research programme. Now, the linkage study is not a clinical trial, and as such it will not provide in and of itself the type of evidence can demonstrate cause and effect for any particular treatment. It's observational in nature, linking and analysing existing routinely collected data for adults who as children were referred to the Tavistock before it was decommissioned. The study requires no active patient participation and instead relies on analysis of digital information held within health records and other databases. Now, the data linkage studies have faced difficulties that are a matter of public record, but since then there have been great efforts to improve the collaboration of the adult clinics and other organisations. Important final steps are currently being taken to enable the study to begin, and we will then expect the study analysis to take around 1 year to complete. On the 26th of February, we laid an order before the House to make it lawful for people and organisations to share or process data that could be subject to protections under the Gender Recognition Act 2004, where it is for the purpose of the study, and that came into force last week. The Pathways clinical trial is a key step that we are taking to build an evidence base to prove whether or not puberty blockers are safe and effective in treating gender incongruence and gender dysphoria. As we speak, the new clinical model is collecting a consistent and comprehensive core clinical data set while we develop a supporting national registry. But in the meantime, hormone medications are not being prescribed. NHS England now prevents the routine use of puberty-suppressing hormones in the NHS Children's Gender Services, and this government has indefinitely extended restrictions that prevents them from being supplied privately. Last year, NHS England issued guidance to GPs that strongly advised against supporting prescribing agreements with unregulated providers who don't always have children's best interests at heart. This includes online overseas providers who are known to have supplied puberty suppressants and cross-sex hormones to children in the past without any proper safeguarding. And NHS England issued this warning because of the serious safety risks that unregulated providers continue to pose to children in this country. And in some cases, we're talking about puberty blockers being prescribed following a questionnaire or a brief Zoom call. Now, I hope I'm coming to some other issues around future services. I think I have answered most questions. To the Honourable Gentleman from Tunbridge, all clinical trials have appropriate insurance to cope with the issues that I think he outlined. With regard to the member for Reigate, the trial sponsor is King's College, so my understanding is that the issues that she would regard with so-called state having conflicts doesn't arise. The Honourable Lady for Bristol Central cited regulations that I think were mainly overseas, but obviously the UK has its own regulatory independent network, and that is obviously the MHRA are the people there that we work with. The Honourable Lady for the Opposition, who I respect in her role as a paediatrician, asked a number of other questions around timing on process, and I will write back to her on some of those issues. She'll also be aware that some issues are part of a there is a judicial review into some of this, but I will make sure that she gets an answer to some of those timing and process issues. I do want to update the House that since April 2024, NHS England has opened 3 new services in the North West, London and the South West, and I can confirm the 4th service will become operational at Cambridge University Hospital's NHS Foundation Trust very shortly, because these are important services for all those young people and their families that are awaiting treatment and want to understand when and how they are going to receive that care. These services, I'm not going to give way, these services operate under a fundamentally different clinical model to the Tavistock Clinic. Children and young people will get tailored, comprehensive and tailored assessment and support from multidisciplinary teams made up of experts in paediatrics, neurodiversity and mental health. Mr Stone, under this government, mental health spending has gone up in real terms, and we're putting specialist mental health teams in every school also to support these young people. But I know that there are still young people and their families out there who are desperately worried by some of this debate and concern about the future. That is often to the detriment of their own mental health, and they want clarity on the options that are open to them. So I want to end by assuring colleagues that we will update on all the issues as soon as possible, and I urge all colleagues to continue to engage on the evidence that best supports our young people. That's what we as a government will continue to be focused on.
And I call on Jamie Stone to conclude the debate.
Thank you very much indeed. I trust that this evening's debate will have given a flavour of what life on the Petitions Committee is like. It brings its challenges and it brings informative debate out of it. I want to thank each and every one of all those who've spoken, and they've all spoken with sincerity. Opinions differ, but there's no doubt that people felt very strongly about the issue. And I hope to thank all those in the public gallery. At the end of the day, the work of the Petitions Committee is about making sure that an issue is properly aired in this place and that the petitioners are heard. I believe that has been done tonight, and I thank each and every one of you. Thank you.
The question is that this House has considered e-petition 751839 relating to the clinical trial into puberty blockers. As many as are of that opinion say aye. Of the contrary, no. I think the ayes have it. The ayes have it. Order, order. I suspend this sitting until 6 p.m.